Welcome. We're so excited this morning on Kennrod Live. We have a guest that we're excited to hear from, Dr. Michael O'Reilly with the CDC and Emory University is going to be with us. So, Dr. O'Reilly, welcome.
Good to be here.
Yeah, it's awesome to have you. And Kelly, of course, with Kennrod is always here. And Kelly, welcome to you too.
Thank you. It's good to be here.
Thank you for calling in your favors to get Dr. O'Reilly on the show. That probably cost you quite a few, but good job. So let's just jump in. Dr. O'Reilly, just share with our audience a little bit about your background and so they know, who is with us this morning and get an idea of just your professional background and some things to share with our audience.
Sure. So I started out as an undergraduate at the University of North Carolina, and I majored in East Asian Studies. I worked for a magazine in New York, and I worked as a landscaper for a while before I went back to medical school. So I got my MD, I got my master's degree in epidemiology, I did a residency in internal medicine, and I completed a fellowship in primary care research through HRSA. And then I went to work at Emory, working in the HIV clinic. And then I really started this outbreak stuff and public health stuff when I did CDC's 2-year program in the Disease Detective EIS program. After that, I spent 15 years in Asia doing field work on outbreaks. And that included 5 years being the advisor for the field the outbreak program in Thailand, working in the Ministry of Public Health. And then I spent the next 5 years in the Philippines. I was working as a consultant for WHO, helping with programs throughout the region, 6 or 8 programs there. And then at around the end of that time, I started the outbreak disease detection and response program in Papua New Guinea. And that was wonderful. It was really a challenge to start a whole new program. When I came back, I had a couple of health issues and I couldn't go to the field anymore. So I've been working as a consultant for industry, and I help teach COVID classes in Emory School of Public Health, including right now, we're teaching the Los Angeles County and City COVID workers, about 200 or 300 folks, on COVID disease detection and response. So,
wow. So a lot of great background, and certainly you've traveled the world and been to a lot of places that most people aren't. So, but thanks so much for being here. So I'd love for you just to share with our audience, like the origin of the virus, and give people a little bit of that, and then, just walk us through a little bit about what your journey has been and some of the challenges we have out there today.
Thanks. And I'm sorry I don't have the pictures here, but the origin of the virus actually comes from bats. And it's bats in southeastern China and the east coast of China. Some of your audience may not remember SARS, the original SARS, in 2003. But that was sort of our initial experience with something that came from bats and then went into another species and then started infecting and killing human beings. We only had about 8 cases of SARS in the US and 0 deaths. But I was in Asia during SARS, and it was really terrible in China, Hong Kong, Vietnam. The official death count for that was maybe 800 or 1,000, but I think it was more than that in China. And this was a disease that came from these bats, and then it couldn't go directly to human beings. It ended up going through a species, a palm civet. It's sort of like an Asian version of a raccoon, and folks in China used to eat this palm civet. And we were able to figure out exactly what market that disease started in And it started with people who were eating the palm civets and killing the palm civets. So, you fast forward another 10 years, and in the Middle East, there's another related virus called MERS. And this time it comes from Egyptian tomb bats, and it goes into camels. And this outbreak is still going on in the Middle East. It hasn't been stamped out. And so those are just the two precursors. About 5 years ago, Chinese scientists discovered 17 different coronaviruses in bats in southeastern China that were all related. And so we knew that this was kind of a worry, a problem. And all of a sudden, here comes COVID in Wuhan, which is the initial cases were near a market. But we don't yet know, with SARS and MERS, we know that bats were the initial species, and we know what the intermediate species was, the second animal before it came to human beings. But we don't yet know what that intermediate species is for COVID. So bats are interesting critters, and we could talk more about that. But what I'd like to go to now is sort of where the disease is in the U.S. And talk a little bit about vaccine, because there are a lot of different things we could talk about with COVID, but the vaccine is preeminent on everybody's mind. So let me show you a couple pictures, and then we'll go to questions. This was the trend line of COVID cases in the United States through October, and you can see we had this initial surge in April when New York City was the epicenter in the world. In May and June, it looked like things were getting better, and maybe we had the chance to control it in the US. Actually, in May and June, it was spreading throughout some vulnerable populations. But we had this peak in July and August. Things came down again. And in October, it looked like we were headed to a second peak. And now you can see that a third peak. The third peak has just dwarfed everything that has come before it. We've actually had over 300,000 cases in a single day, which is just remarkable and really sad. And right now we're in a hot zone. If you look at it in terms of where in the US is there a whole lot of disease, this is a heat map, and the redder colors show where there's a lot more virus, a lot more people getting sick. This is where we were in November. It had gone up into the Midwest and the upper Midwest. But now this is where we are now. California and Los Angeles is the epicenter within the US. Epicenter is just a technical term that says the hottest spot, where the disease is really, activity is the highest. And see, in South Texas, it's awful bad too. In terms of deaths, we've had success in some treatments, steroids, and some other medicines. Steroids probably the best thing so far, and we had been able to treat folks and test them and catch them earlier. Try to not put them on the breathing machine, the ventilator. But through the middle of November, we were climbing again. And where we are now, again, very sad, but we have far eclipsed even the previous peaks. So this is a bad disease, and more than 4,000 people a day are dying, which is, it's an incredible burden. This is massive. A massive amount of death has come from this virus. And most of the virus actually has come from New York City, including in our own Southeast. Over 80% of the virus here is traceable back to New York. So, in my kind of work, when you're trying to figure out the detective part of outbreaks, you want to know where it started. It started in bats in China, and it spread to various parts of the US. New York was the most important part, went out into other places. But who's it hurting the most? And it's hurting minority folks and older folks. This is where the first nursing home outbreak was in the US. And as of a week ago, there were over 135,000 deaths in nursing homes. The little graphic here shows in our part of the US, the rate of death per 100 nursing home residents. And we're less than some other states. You can see Indiana has triple Georgia's rate, but still 1% of people dying in nursing homes is really bad. Now, I talked about who's been hurt the most, and this is a CDC study, and you'll see that Native Americans, Hispanics, and Black folks have really been hit hard, and these are rates compared to white people. So if you look at hospitalizations here, you can see that for Black folks, the rate is 3.7 times high what the rate is for white folks, 4 times for Hispanics, 4 times for Native Americans. So, and for death, it's, between 2.5 to 3 for all of these groups. So the disease has really hit minority populations tremendously. And American Indians, this is a woman, Valentina Blackhorse, who was a Native American beauty pageant winner and was an advocate, a public health advocate, and she died in May. CDC did a study closer to home, and they looked in, this is Fulton and DeKalb, and they did a serology study, and they estimated that 0.3% of white people had COVID, 17 times that, 5.2% of African Americans had COVID. So it's now this, that data was from early in the epidemic. I think a fuller study would show maybe not 17 times, but still, this really highlights how African Americans have been hit in our own area. One reason, folks say, well, why? Why has it been so bad? And one reason is that we're not doing what we're supposed to be doing. And I just wanted to show you about one outbreak in Missouri. And in Missouri, there was this hair salon. And there was this woman who was working there, and she was sick with COVID, and she was coughing, and she was having symptoms. At this hair salon, they had a policy, 100% of the time, you had to wear masks when you were working with clients. So not when you were hanging out with your fellow worker, and obviously not at home. This woman infected all 4 of her close family members, and she infected a fellow worker, but neither she nor the fellow worker, they were near 139 clients in the week or so that they were symptomatic. 0% of people got COVID, 0, because everybody wore a mask. And so we really do need to be wearing masks. Now, I wanted to talk to you about vaccines, and I'm just going to look at this stuff quickly. There's 4 vaccines that are going to be approved by the middle of the year. Pfizer and Moderna are the 2 that have already been approved. And they're this new technology, mRNA. There was an Ebola vaccine that had been developed that was using mRNA, and a couple of others that were under development, but really this is a brand new technique, brand new technology. And the goal for the FDA to give emergency use authorization for vaccines was 50% effective or efficacious. These 2, Moderna and Pfizer, 95% within a year. Stunning, a miracle, really. Has the potential to save many lives. And so on December 11th, the FDA gave this EUA, this authorization to Pfizer, and a week later it gave it to Moderna. Now these are 3 slides that I'll hold off on now, and I'll stop sharing, but I'll go to this if folks have questions later. And I think now is a good time to stop my sharing and if I can do that, and we'll just go to
Yeah,
questions.
we were able to stop it, so we can
Great.
go back if we need
Okay.
be. Oh my gosh, I am like stunned. I guess I haven't had an opportunity to have it all presented in such a way to digest it. You get bits and pieces from different sources, but now I guess you're in the bigger picture from a person like yourself, and I guess, I mean, I know my mask wearing, yeah, I wear it, but I'm not like so adamant about it. My daughter got it about 2 weeks ago, and now my wife
Yeah.
said, "Did you wear your mask? Did you wear your mask?" And so maybe it's hit a little bit home to know that, that's the reality of it. So yeah, that's some incredible information. So I know from the vaccine, I just heard the other day. So we've got another one coming out, Johnson & Johnson, and that's a one-shot vaccine. Vaccine. Is that
Well,
true?
there are 2 or 3 that are about to come out. One is AstraZeneca. AstraZeneca is only 65% effective. It's already been approved in the United Kingdom. It's kind of funny, though, with this vaccine, because they studied it, they did trials in 3 different countries. And Oxford University, which is a real prestige university, and they were kind of embarrassed because a couple thousand folks only got half of the recommended dose, as it turns out. And when they studied it, they found that the people who got half the dose, actually, it was 90-something% effective at preventing COVID. But people who got the full dose, it was only 60-something effective. So folks
Wow.
are still puzzling over that one. And I would say the Johnson & Johnson, I don't think it's been approved yet. And the Janssen, I know, it'll be a one-shot vaccine. But we're getting more information every day about the vaccines. And if people have specific questions, I can go into that.
Yeah. So why is it that there's 2 vaccines? I know people have, asked or people have
Right.
said, but I've never heard an answer. So I'm just curious. Maybe some
There's
of our
actually 120 vaccines that were under development, and a number of them, a good at least 6, maybe more, got money from Operation Warp Speed. I mean, typically it takes years to develop a new vaccine, and that vaccine would undergo FDA approval. Now, in an emergency like this, just the approval process would take more than a year. In an emergency like this, we can't do that. So we're using emergency use authorization, which is a speeded up process. And it includes monitoring after the vaccine has been released. But I think we didn't know how effective these were going to be. To be honest, I think most people were surprised, shocked that it was 95% that Moderna and Pfizer, the level of effectiveness, really surprising. So, the idea was to throw a lot of arrows out there and hope that some of them would hit the target. And our technology has actually done pretty well.
Yeah, I guess the enormous task of vaccinating, a country and then the world is like unprecedented. Because you have a small breakout and you have a vaccine, spread it out over time. So kind of speak to that. I mean, I know we're in the process of it.
Yeah. So
Incredible.
it really isn't. Some people were saying, wow, the vaccine is, now we know we've got a successful vaccine. Wow, haven't we accomplished something? And actually people who had the experience, they were saying, you know what, now that we've got successful vaccines, our work has only started. Because rolling out a brand new vaccine for over 100 million people, potentially 200 or 300 million people, it is just extraordinarily complicated. And you can see that with the sort of complications and some degree of dysfunctionality with the signups now and with the getting vaccine in. It's just an amazing thing. I think that my understanding is that the new administration is going to try to help the states and the counties and actually set up federal vaccination centers. But the vaccines themselves, there are some complexities, and not everybody wants to get the vaccine. We have this issue of hesitancy, and that's a big concern. I'm not a guy who wants to, pass laws to try to vaccinate people, but I think there's a lot of work to be done in terms of educating folks about the vaccine. What do they do? What do they not do? What are the side effects that folks have seen? At what rate? And then let people decide. So.
On that note, Pete, if I could speak just a little bit. First of all, I just want to let our audience know that we are so fortunate to be able to have Dr. O'Reilly with us today to kick off 2021, because we know that COVID-19 is top of mind for so many people, for most of us, not just here in the US, but across the world. We know the impact that it has had. And for Dr. O'Reilly, for you to be able to take time out of your busy schedule right now to share this knowledge with us in a way that can be easily understood to our students, our families, and the greater community about the origin of COVID-19 and where we are even here in Atlanta to date in terms of how it has been affecting people. So I do want to take this opportunity before we get too much further into our program just to thank you for being here with us. There's so much information, but we're going to be able to condense some of it and might have you come back later sometime to give us an update. But even as you were speaking about the different vaccines, one of the things that I've heard is some people are hesitant, as you mentioned, about taking the vaccine, and particularly about the first two vaccines having the mRNA, and then they're waiting for the next vaccine being Johnson & Johnson, because there's a one dose, and whatever it entails does not have the mRNA. So can you speak to that a little bit? Because there's some that are more knowledgeable about the medical, the science behind that, and we want to give our viewers a little bit more insight.
So the traditional ways of making vaccines, that's a great question, by the way. Traditionally, what we would do for vaccines is either we'd take killed virus or killed bacteria, chop it up, get little pieces of protein, and you introduce that to the body. And then your body sees it and it responds and you get immunity. Or we would put in a dead virus or a weak virus and have the body be able to recognize this foreign substance. Now, I've got to look more at Johnson & Johnson, and I don't have all the specs for that. I do for Moderna and Pfizer, but a single dose may not be as effective as Moderna and Pfizer. 95% is really, really good. And I think the other thing is, if you look at, for instance, flu vaccine, Moderna and Pfizer are way more effective than that. One of the most effective vaccines is measles vaccine, and that's in the ballpark of where Moderna and Pfizer are. I think that I guess I would stop there in answering that.
Yeah.
Awesome.
I think some of the hesitation is that obviously we had to jump right in and find solutions, and there has not been the time that we have had in the past for there to be trials and for there to be research. And now here it is, go ahead and take it. But there's a lot of unknown that unfortunately we won't know until we have more time.
Well, I think I think that the side effects are, most of them are not that big a deal. Pfizer, 4% of people the day after the second dose will have enough fatigue or muscle aches that they'll want to take medicine or maybe not be at school or at work. And with Moderna, it's a little higher. But those things are minor, and all vaccines have a little bit of that. The real issue is anaphylaxis, which occurs for the Pfizer vaccine. 11 out of a million people who get it have anaphylaxis. Anaphylaxis is a bad reaction, allergic reaction, and it can cause problems breathing. And that can, it is potentially life-threatening. But of the 21 people who've gotten anaphylaxis from Pfizer, 17 had a known history of allergy, 7 had a history of anaphylaxis. And of those 21 people, only 4 were hospitalized. Everybody got better. Now, I do note that yesterday, a batch of 330,000 Moderna doses of vaccine were recalled because there were 7 or 8 cases of anaphylaxis in San Diego associated with that batch. I've had a bad reaction to a vaccine, potentially life-threatening in the past. I would get Pfizer or Moderna tomorrow if it was available to me tomorrow, because,
I have, and Kelly knows this gentleman, but he's in our business group, and 10 people in his family got it, and he got it the worst, to the point 3 weeks, 10% lung capacity.
Yeah.
He said like death, close to death. What is when you hear it, some people get it real bad and some not, and they're all in the same family, caught it at the same time. What happens there? Is there anything we know?
We know that the rate of household transmission, household close contact transmission, initially we had thought, gee, maybe this is only about 20%, but now we know from studies in Tennessee and Wisconsin that it's about 50%. And we know that there are certain things that are big risk factors for getting really sick or dying. And those include emphysema. So a lot of times folks who've been smokers, heart disease, autoimmune or immunodeficiency. So if you're taking drugs for cancer or for rheumatoid arthritis or lupus or something like that, those folks are all and increased age. Those folks are all at greatly increased risk. But there's a lot of asymptomatic transmission, and so it's hard to know. You have to be really careful in doing a study because you want to catch the asymptomatics as well.
He had talked to somebody that, was in the medical community and, said that it's not like this is science or anything, but just an educated guess that the amount of like droplets that you inhale might affect how a person, the degree of the virus on that particular person. Because this guy's as healthy as a horse. I mean, he runs and all that, and he works out, and so he got it the worst of anybody in his family.
So
is there anything to that, or is it just too early to tell?
Well, the inoculum, how much viral material you bring in, that's really hard to measure. We know a little bit about that from really carefully controlled studies in labs that the NIH do looking at masks. And so what we know that masks, for instance, with other coronaviruses, the kind that just cause the common cold, that masks really prevent a lot of the broadcasting of the droplets, the virus in droplets and in aerosols. Droplets are small, aerosols are teeny, and they float and they can go a long ways. But it's, there isn't, we don't know. I mean, early on there was the idea that a blood type A was more at risk. I'm not sure where all that, where the latest data is on that. But there are some folks there are athletes who got myocarditis. Think about the Red Sox pitcher. This is a guy in the prime of his life, 27 or so, and he was really knocked out. So there's no guarantees.
And then I've heard, getting it a second time, that some people have gotten it. So
yes.
Are you less likely or more likely to get it a second time? Or is there anything?
So, yeah, that's it. That's a real good question. We know from a fishing boat out of the Northwest where they had actually done serology, and they found on this fishing boat of about 100-something people, 3 people had already had COVID. They hadn't known it. And the boat goes out, and one person, despite having tested everyone, one person was positive. And so more than 90% of the people on the boat got COVID. None of the 3 who had it got COVID. And they had it, we don't know exactly when, but we do think that you're protected to some extent if you've had it. At the same time, there have been studies that have absolutely documented repeat infection. Whether it's with a new strain or not is sometimes difficult to know. It's really hard to know if someone has a second infection, because to prove that, you have to have symptoms, and then you have to isolate the virus. You have to culture it and isolate it. Usually we don't. We just do a PCR test. But if you're positive today, your PCR could be positive 3 months from now. And so just having a PCR that's positive 3 months apart and symptoms, we don't know if you've got the common cold for the second one. So only in a small percentage of cases do we really evaluate whether or not someone truly has a second infection. So it's probably uncommon, but we don't know really what the rate of second infection is. And we don't know how long you're protected after you've had an infection. So.
Awesome. Speak to our students, because a lot of our audience are students that the Kennrod, group wants to reach, because we want to give them educational opportunities, expose them to people like yourself.
Yeah.
So maybe the biggest challenge you face in your position, and then people that might be interested in pursuing the path that you have. Can you give them a little bit of insight into that?
I think the biggest issue, I'll talk about Georgia camp outbreak and about the Georgia public school outbreak. North Georgia camp, 500 to 600 kids, and every kid, this was the governor relaxed the regulations on overnight camps around the beginning of June. And we were actually going lower. We had maybe 5 cases per 100,000, a little bit over that, 6. And so we opened up a little bit, and camping is a huge industry in the US, like, billions of dollars. And there are 15,000 overnight camps in the US. And this camp in Georgia did a really good job. They said every single camper has to have a negative PCR, the best kind of test, within 12 days of when we start camp. And all the counselors are going to wear masks. They figured the kids, they weren't going to, so a counselor, that camp opens on Monday. A counselor starts to get symptomatic Wednesday, test positive Thursday. They start sending the kids home on Thursday. Over 50% of the campers and counselors who are tested are positive. Hundreds. 260 or something out of 500 or so it was a crazy number. So it can happen, it can spread really quickly. When you're in school or in camp, you're around a lot of folks, and you also may have gotten the message COVID isn't that big a deal for you. It is. There are things that just affect kids with COVID. Bad disease that can kill you, that just wipes out all your organs. And it's not the virus, it's actually your body's getting too excited in response to it, and you start eating your own organs with that. That's a terrible thing. It's not common. But in Cherokee County, the pictures were in the news, I think, of the first day of school, all the kids crowded in the hallway, and nobody wearing a mask, and you see, within 2 days, there's a letter out to the parents from one school in the county. And then within a week, letters to parents at 11 schools, and 2,000 kids were quarantined at home, or 1,500. It's just, I think what we don't realize is how connected we are in the world. And it's, you can get it and transmit it to somebody else. And it's not just about you getting sick. It's about your parents and your grandparents. It's about the folks who work in the grocery store. It's about everybody. And I know it's a pain to wear that mask. I hate it. I hate doing Zoom. I hate this virtual stuff, but we got to do it for a little while longer until we can dead end the virus with vaccine and other things. And in terms of my education, I guess the one thing I would say, when you're thinking about high school and you're thinking about college and folks don't know what to do, if I had to do it over again, I think the thing that would be most useful would be to say, I want skills. I want to be able to analyze stuff. So I got to understand some math. I got to be able to understand how graphs work. I got to understand some statistics, or I want to be able to communicate clearly. And so I want to be able to take, a source of information or multiple sources and sort of synthesize, look at it, figure out what I think about it, and then communicate that. And there's a bunch of different ways that you can go about that. But I would think of education as a way of getting skills. And I think that, I went roundabout. I was a landscaper. I was a journalist. I didn't finish the EIS disease detective program until I was 40. And one of my old professors from med school who had been in that program 40 years before, he told me I must be the oldest one ever. I was not, but it's okay to be roundabout. But I think if you, everybody's life takes different paths, but getting skills and thinking about what skills you want, I think that's a good thing.
I totally agree with you. I have 2 daughters, and I tell them all the time, get as much skills as you possibly can.
Yeah.
Get exposed. I think you're traveling around the world and getting exposed to different cultures and doing so many different things prepared you for what you're doing today, would you say?
It's funny. I had done some training in New Zealand and in Scotland, and I had done a little bit of travel. I mean, my dad never finished high school, and we had one bathroom with 5 or 6 people at home, so I wasn't coming from a place where everybody went to Europe in the summer. But when I went to work in Thailand, that was when I really learned. And the first thing I learned was almost all these people were far more capable than me. They had been doing a lot of outbreaks, and to learn from people around you and really be able to work together. There was a great spirit of collegiality there. I was one of 4 who were staff members there. Mm-hmm. And the 3 senior Thais all were physicians, and they all had PhDs in epidemiology. I just had a master's degree. And I always thought, gosh, that's amazing. And folks would come from Geneva, from where WHO is, or from Atlanta, where CDC is, and they'd say, oh, well, we know how to do this better than they do. And I'd say, see that woman over there? She's done 200 field investigations. She can walk circles around you. So I think the best thing I did was try to learn from people initially who you weren't certain initially. I came in and they thought I was the expert, but you gotta not take that attitude.
It's so exciting for you to share that, Dr. O'Reilly, because that's exactly the mission of Kennrod, to make sure that we're exposing our students, many of them who have not had the benefit of even going beyond the city of Atlanta, but being able to, through Kennrod, be exposed to people like yourself, actual practitioners who are doing the work and can share the background that you're sharing right now, makes such a huge difference. So this is really what we're about. And it's really about not so much where you came from, as you pointed out, your upbringing. And when I think about my own upbringing, but it's really about being exposed to others and having the drive to want to get to a certain point and the will to get there. And to really, really see and hear from you, I think that there are going to be a lot of kids and adults that are going to be inspired, if not to go into the same field, but to be inspired to seek out medicine. And I think you sharing today speaks to a lot of that. If you could, before we wrap up, I'd also like for you to talk about, you mentioned that Los Angeles is the epicenter now for COVID, and you are training doctors and nurses, and this is such a huge time for them, such a very anxious time for them and frightening time for them. And many of us think about them all the time because they are our heroes, especially in this moment. How do you encourage them? And can you give us a little bit of insight on the work that you're doing with them?
Yeah. Well, we've been, teaching at Emory health professionals on COVID surveillance and response since maybe April. And the folks at LA we actually spoke with some people from New York, but we didn't end up working with them. And then LA talked to us, and they wanted things a little bit in a slightly different format. And it was my curriculum, and when they wanted to change it at first, I thought, but what I think a lot of what they're trying to do is we can only do about an hour twice a week because these folks are so busy. And so they really want practical stuff, which is great because, if you think about it, some guy who goes over and spends his life in Southeast Asia is not the same as a professor at Harvard with this stuff. You got to do it practically. And I think, the way that you inspire people is just, I hate Zoom, but I try to make it as interactive as possible. So if I see someone saying something in chat, I'll recognize that, and I'll say, okay, meet with the producers after the show. You're going to get a prize for that. And of course, if in person, you might have, bags of candy that you'd toss to folks when they give a great answer. But and getting them to build up the relationships within their own teams and appreciate, what good work folks are doing. And I make sure that we use data from Los Angeles as much as possible. I remember starting once, and 25 years ago, and I had this guy who was like the most famous person in the world doing this kind of work, and I was his sidekick in it was either Malaysia or Cambodia, Vietnam, one of those. We did a 2-week course in one of those countries, and we were presenting data on a diabetes study in the US from 30 or 40 years ago. Everybody's going to sleep in the class, and it's not just because they're having a hard time with English. So I think you got to make it real for everybody and say, this is your experience. And in Los Angeles, there had been a serology study done that suggested that being Hispanic meant that you had half the risk of being white. And that came out just before they released a report. And it was based on this serology study out of Stanford and maybe USC. And it was based on 35 positives out of 1,700 people who they had taken blood from. Whereas LA already had 19,000 confirmed cases. And they had, it turned out, more than 40% increased risk for Hispanics. And so the fact that they did that, and I had a couple of suggestions about ways to do it, but the fact that they did it, I thought was wonderful. And it had defeated this potentially dangerous, limited study that said, you're not as at risk. The plurality in ethnicity in LA is Hispanic. So if you're saying Hispanics aren't at risk, you're not going to put as many resources there. You're not going to have as many testing centers. You're not going to have as many contact tracers there. So I told them, I pointed that out, and I think it was wonderful.
What about when it comes to the vaccine? Kelly, help me out here. You're an
Vaccination, Pete?
Yeah. Yes. Across the world, I know we have our policy of getting them approved. How does that affect other countries and what's available, in these other countries to?
Yeah. So the EU and the UK, the European Union and the United Kingdom, they have processes that are similar to ours. Now, the UK has already approved AstraZeneca, but it's an Oxford University vaccine. So there's probably a little bit of an advantage for that vaccine when it's a homegrown one. The EU is really similar to us and UK, but in developing countries, sometimes they'll rely on what the EU regulators or what the FDA regulators have done.
Mm-hmm.
And sometimes they just go out and get what's available. So for instance, China has 5 vaccines and Russia has at least 1. And they don't go through this process. So we don't know how effective they are. They don't share the data. All they do recently, Russia said that for their vaccine, they were 90% effective. And there are smart scientists in Russia. But if you don't share all that data, I'm not sure that I trust that. China, its sort of lead vaccine that's been used in South America and maybe a bit in Africa and a few other places, they said 70%, 70 something. And I think those were more traditional technology. 70%, that I buy that. 90%, I got to see the data. But the Chinese vaccines, there have been issues with quality control. Rabies vaccine, they were found to give just fake vaccine about 5 years ago. And so a Chinese court, really, it closed the vaccine company that did that. India has the ability to make a lot of vaccine, and they've just started vaccinating their folks. I'm not sure if that's from their own company, but they're also, the Gates Foundation has funded a network called COVAX, and their goal is to get vaccine to 190 countries. And with vaccine, sometimes the fact that we've done warp speed, that's good for us, might be bad for African countries because we've bought up all the available vaccine. And some people think that COVAX might get 20% of people vaccinated by the very end of 2021. Others are saying that's overly optimistic. So there's this issue of global equity that folks recognize. Gates has tried to support ways, but I think it's going to be imperfect.
I was reading somewhere, and it might have come out of the CDC, but they said that the person made a comment, this could be around for a long, long time, meaning, we'll always be trying to keep it in check. Is that what you're hearing, or is it too early to tell, obviously?
Well, I think there's a few issues behind that. One is, can we get to herd immunity, and what level of immunity is going to be successful? Because if you get to the point where enough of the population has immunity, then the virus dead ends or dies out or almost dies out. That's our goal. People estimate anywhere from 55 to 82% is what we'll need for the herd immunity to be successful in the US. But what we don't really know is how long is the immunity, how long lasting? So these Moderna and Pfizer are 95% effective. We know for sure they're at least 2 months. You might say, oh, only 2 months, but we don't know until we've had a lot of people vaccinated for a long period of time. The Moderna CEO the other day said it would be at least a year in his, and he's probably got some data that I'm not privy to, but there's the possibility that for a while at least we'll need annual vaccinations. It's unclear. For if you've had COVID, we don't know how long you're protected. We know that within 2 weeks, 92% of people have detectable antibodies. At 3 months, that goes down to about 50%. Now, that doesn't mean that you've only got 50% protection. You've probably got some protection that's just we're not seeing in the test. But the other thing that comes into play is the new variants, the mutations. And as I think a lot of people heard about B117 out of England, and people may be hearing now more, we're detecting new variants in the US. We had not been actually doing a lot of surveillance on this until recently, until we heard about B.1.1.7. And now we're hearing about a lot of different strains in the US. All viruses mutate, and most of the mutations are not significant. So some of this, we're going to have to wait and see what happens. But the more hesitancy there is, and this is why I responded a little bit negatively to Kelly saying some folks want to wait until the one-shot vaccine comes out. The more we wait and delay, the more we're at risk of not getting to that level of herd immunity, and the more we're at risk of having this be a problem next year and potentially further on, and nobody wants that.
Nobody wants it.
Yeah, and it's totally different to be vaccinated for the flu and some of these other. It's a personal thing because you don't want to get it, but we're
Right.
talking about something that it's not about you. It's about who.
Well, flu vaccine. Interestingly, I helped set up the flu surveillance in one country, and then we would send what they do with flu in the southern hemisphere. They get flu before we do. So our vaccine comes from a bunch of labs in the southern hemisphere that will collect different isolates, and they'll culture flu specimens, and they'll say, oh, this is type X, type Y, type Z, and then they'll make a menu, and they'll have a little recipe, and so for every year we change the X, Y, and Z. But flu, in the last 10 years, the effectiveness of flu vaccine has been over 50% only once, maybe twice. So it's it does stop death. It's a good thing to get, no question. But it's nowhere near as effective as the vaccines that we're looking at right now. I mean, not even remotely as effective.
That's interesting, and to share that, because I didn't know, and I've always chosen not to, just for personal reasons.
Well,
this is a different situation.
As you get older, it's more important for you to think about getting flu vaccine because your risk of dying is higher.
Totally. What do you think when it comes to getting back into sizes of like 50 people? In your best estimate, when would you see that in the U.S.?
Well, right.
With that thing?
Right. That's an excellent question, and it's Kelly and I belong to the same Rotary Club, and we've been wondering, like, when do we get and meet in person? And I hate virtual. I'm an Irish guy. I like being around people, having a cup of coffee with someone. So I really am impatient. But the way to look at this is to look at the number of cases in, say, a county per 100,000 population. And just to stop somebody's opinion, somebody else's opinion, and to get everybody on board and say, we want to get this number lower. We know that by wearing masks and social distancing, we can bring it down. And I think, people have said over 25 is critical. We're way over 25 now. I think we need to get to under 10 to really start having big gatherings, and under 5 to really start thinking about really loosening regulations. Wearing masks and social distancing, they're good, but nothing's perfect. And it's like a bunch of Swiss cheese. Masks are not perfect, so there's a hole. Distancing is not perfect, so there's a hole. But if you put all those slices together, one next to each other, then the holes don't line up, and you minimize the transmission. So I would say, I would recommend for governors, for county leaders, for presidents, that they say, okay, we're going to make this based on the number of cases in your community. And once you get to a certain level, it can go down. And then everybody can get behind it. Because right now, it's a pain to wear a mask. It's a pain to social distance. And folks don't see why, and they don't see the end point. If you told them why and what the end, if you made it a common goal, I think it would happen more. And so, if you think about Sturgis, for instance, the motorcycle rally in South Dakota, 460,000 people gathered in a week. Nobody was wearing masks. And they're all sitting, eating, and drinking next to each other. Biggest risk factor for getting COVID, aside from close contact to someone known to have COVID, is being in a bar or a restaurant or a coffee shop, eating or drinking indoors. or maybe exercising, maybe gyms. So, you look at Sturgis and it was outside, but picnic tables, everybody rammed together, and a lot of folks died, and we were able to trace, this guy who died in Illinois. Yes, that's exactly the strain that came from Sturgis. And I get it. I get why people are frustrated. But I think if we had this goal that was a number goal, I think that would help a lot.
Yeah, I think you're right. I mean, that's a good point, because we don't see light at the end of the tunnel sometimes when it's a general, hey, we just got to do this. But if you have numbers that people are trying to achieve,
Yeah.
and when those numbers go up and down, that you're going to do certain things, I think it gives people a sense of confidence that there is a reason right now to do what you have to do, because you want to get it under control. So that makes a whole lot of sense. So, okay, well, that's Kelly. Do you have any questions that you
Well,
would?
I know that this is, we've come to the point of preparing close this presentation. And I just really want to thank you, Dr. O'Reilly, for taking time out of your schedule. This has been invaluable information, not just for Pete and I, but for our community, for the Kennrod community. And we do hope that those of you who are listening will share this with your family and your friends, because we want to make sure that we are as informed as we can possibly be, and that we do our part to stop the spread of this virus. I mean, hearing just yesterday that over 400,000 lives have been lost, there's a lot of people behind that number. And we really, really have to do our part individually to try to make sure that we stop that. So I just want to thank both of you for the time this morning. Dr. O'Reilly, I hope that you will continue to stay engaged with us. We, of course, have presence on social media and through our website for updates. And Pete, I just want to thank you for being a resource for us. Kennrod would not be able to have this platform if it were not for Digital Growth ATL. So thank you so much.
My pleasure. It's, I know with the work that you're doing, Kelly, with bringing educational opportunities and awareness to people that might not have those resources is a wonderful, thing that you're doing. So anything we can do to help spread the word. And yeah, certainly, Dr. O'Reilly, thank you for being on. I mean, I know you're busy during this time, and taking the time out of your schedule to share this has certainly been a benefit to our viewers and the people that will see this afterwards. So thank you.
Thank you, folks, for having me.
You're welcome. Have a great day, everyone.
Awesome, y'all. Thank you for tuning in, and thanks again for a wonderful show, Dr. O'Reilly. Thanks, Kelly.
Thank you. Bye-bye.